Welcome. In these sessions, we are doing a deep dive into pulse oximetry, not the basic version, but the critical care version. We'll cover the physics, the hidden limitations, and exactly when you should stop trusting that number on the screen. If you work in an ICU, emergency department, or on a code team, or you are a nursing student, then this is for you. Now let's begin. Pulse oximetry estimates arterial oxygen saturations without drawing blood. It has become the fifth vital sign, but in critical care, we know it's not infallible. It's, it is inexpensive, portable, and continuous, which is why we use it on almost every patient, especially in ICU. But as you will see, the devices makes assumptions, and when those assumption breaks, so does your data. So we must understand the physics or how the pulse oximetry works, and when can we trust the number on that screen. So now let's discuss on principle. The principle that is used in the pulse oximetry is the photoplethysmography. So it measures the changes in the light absorptions caused by the pulsatile expansion of the arterial blood volume in each beats, and the physics foundations is based on the Beer and Lombard law. This is the two law. So the Beer's law says that the amount of light absorbed is directly proportional to the concentrations of the light absorbing substances. So that means if there is a low concentrations, there will be a low absorptions, and similarly in a high concentrations there will be a high absorptions of the light. And the Lombard law says the longer the light travels through the blood, the more it gets absorbed. So here the absorptions and the path lengths are directly proportions. So if there is a less light path length, there will be a less absorptions, and if there is a more light path length, that means there will be more absorption. So and pulse oximetry works on principles of Beer and Lombard law. Now let's just see how does it works. So in pulse oximetry, there is a probe, and the probe contains two emitting diodes that emits monochromatic light at wavelengths of 660 nanometer, that is a red light, and 940 nanometer, that is infrared. So the red light at 660 nanometer is the same light you see when you look at the probe, and the infrared light at 940 nanometer is invisible. This light wave passes are sensed by the photodetector present, and the oxygenated and deoxygenated blood absorbs light at different wavelength. Oxyhemoglobin absorbs less red light and more infrared light than the deoxyhemoglobin, and vice versa. So here you should understand that oxyhemoglobin absorbs infrared light strongly and red light weakly, and the deoxygenated hemoglobin does the same opposite. The ratio of absorptions between these two wavelengths gives the devices its raw data, and then it calculates. So you can see here, this is the wavelength and this is the absorptions. So the deoxyhemoglobin absorbs more at red light, and the oxyhemoglobin absorbs more at infrared light at 50 to 60 nanometers. Okay, so when the artery pulsates, the distance traveled by the light through them changes. That is based on the Lambert law. Therefore, it can measure changes in how much the light takes it through the pulsatile device. In pulse oximetry, the path length changes with each beat because the artery expands. That pulsatile change is exactly what the device measures. It subtracts out the non-pulsatile tissues like skin, bone, venous blood, and isolates the arterial signals. That's the genius of it. And also its weakness, because if you lose the pulsatility, you lose the accuracy. And after getting the absorptions of the light at different wavelength, the devices has its raw data and it calculates the SpO2 by total ratio of oxyhemoglobin to total hemoglobin, and used to define the fractions of hemoglobin that is saturated with oxygen. So remember, the pulse oximetry provides the calculated value. It's not the direct measurement, and the calculation assumes only two species of hemoglobin, that is oxygenated and deoxygenated. So the other than this, it cannot provide the accurate informations. That will come in next slide also. So now what are the types of oximetry? What types of oximetry do you know? As a critical care student, you must also know the types of oximetry. So what are the types of oximetry? So there are two types of pulse oximetry. One is transmissions pulse oximetry and another is uh, reflectance pulse oximetry. Most of you must be familiar with the transmissions oximetry that we use in finger, toe or earlobe, in which the light goes through the tissues. But in critical care, you sometimes use reflectance probe, for example on the forehead. These are useful in low perfusion states like shock or in patient with burns or edema where you cannot place a traditional probe. So the transmission pulse oximetry is the most common one, in which the light beam is passed through the detector on the opposite, and the reflectance are less common, and here the light is reflected or backscattered. LED light and the detectors are on the same side. Also, the reflectance pulse oximeter probes are more sensitive to the motion artifact and ambient light. However, they can be a useful probe during the low perfusion state. So we should know both when to use these its speeds and its speeds fall and its merits. So here in the transmissions pulse oximetry, you have the light beam being passed through and the detector is present on the opposite side, where on reflectance pulse oximetry, as per its name suggests, there the LED and the photo detectors are present on the same side. And this is also the same thing being explained earlier, and this is one of the reflectance pulse oximetry that is used on the forehead. And now the uses of pulse oximeter in critical care setting. Pulse oximeter is indicated anytime, anytime, and where oxygenation is most concerned, which is almost always. So it is indicated in any situations where arterial oxygenation is concerned. Some of the examples are during the endotracheal intubations, cardiac arrest, procedural sedations, patients with respiratory disease conditions like asthma, COPD, respiratory complaints, ARDS, persons with sleep disorders or sleep apnea, sons in cyanotic heart disease. As I said earlier, while it is mandatory for all the patients in certain areas of hospitals like ICU, OT for the patient safety. And now, can you say what are the limitations of the pulse oximetry? Just think of it and we'll discuss. Yes, let's get clinical. These are the real world problem of the pulse oximetry, and that is the source of error in the signal measurement that could be due to the ambient light. For example, surgical light or infrared warmer can swamp the photo detectors and can provide an inaccurate SpO2. Similarly, the nail polish, especially the dark colors, absorbs red light. So just make sure you remove it or rotate the probe sideways. And other limitations of pulse oximeters are error due to the failure to detect the pulse, like in poor pulsality of the flow, for example in shock or while using the tourniquet, patients with arrhythmia or the venous pulsations, for example in severe tricuspid regurgitations. What happens in poor pulsality? This is a huge error in shock on high dose vasopressors or during the hypothermia. Peripheral pulses are weak. The device can't find the arterial signals, and the result is no reading or falsely low one. In that case, try the ear forehead or just get an ABG done. Similarly, on atrial fibrillations or arrhythmia that causes beat to beat variations in pulse pressures, the devices get confused and you will see an erratic waveform and fluctuating number. So, similarly, on venous pulsations also, in severe tricuspid regurgitations or high PEEP, there is a venous blood pulses backward. The devices can make mistake for that arterial pulsations and can give you a falsely low SpO2. So what is the clue? Look the waveform for the venous pulse like low amplitude or no dicritic notch on the waveform being seen. And other limitations are source of error in signal processing, like inaccurate. So this is a processing error. So it is about the calibrations. Most of the pulse oximeters are calibrated using the healthy volunteers with the saturations down to above 75. So it is calibrated on the level of 75 to 100%. So below that the algorithm extrapolates. So an SpO2 of 60% that is shown could be either 50% or 70. We never know because it has been calibrated only up to 75 to 100%. So don't make treatment if you see a very low saturations. And the decisions of treatment should be based on the patient clinical scenario. And another, racial biased in dark skin, and there has been a landmark paper also in NEJM. So we shows that black patient had occult hypoxemia nearly 3 times as often as white patients. The device overestimate true saturation. If your patient with dark skin looks hypoxic but the normal is normal, believe your patient get an ABG. So dark skin can also false causes falsely low readings. Similarly, another is that uh, it is inevitable, there is inevitable differences with ABZ value due to the processing artifact. Even under the ideal conditions, the SpO2 from the pulse oximetry will never match the SaO2 measured by an ABZ. There is a differences of plus minus 2 to 3%, which is expected, but the larger differences might indicate a problem. If you see a discrepancy between the ABZ SaO2 label and SpO2 label, always trust the ABZ, but also ask why they disagree. Mostly, the answer is the physiological or the technical problem that need fixing. Another is interference with the absorptions. So this is where inexperienced clinicians might get trouble into. The presence of dyes like methylene blue, indigo carmine. So methylene blue is used in vasoplasic syndromes or methemoglobinemia treatment. It absorbs the light at both 660 nanometers and 940 nanometers, causing an immediate false drop in SpO2. So during the use of this dye, do not panic if the saturation is low. Correlate with the ABZ and clinical scenario. Similarly, the presence of carboxyhemoglobin and methemoglobin might also cause an erroneous SpO2 label that is shown by the monitor. So, in what happens in carboxyhemoglobin? In carboxyhemoglobin, uh, the device reads carboxyhemoglobin as oxyhemoglobin because their absorption spectra overlaps. So you see the saturations level way more than the patient's actual saturations, and there is a trend of 98 to 100% of SpO2 shown in the monitor, while the patient is actually at 60 to 70% saturations. So what is the clue? The only clue is the clinical suspicion and use of co-oximetry. Another is methemoglobin. Methemoglobin also absorbs strongly across the both wavelength, and SpO2 will drift towards 85% regardless of true oxygenations. So think of oxidizing drugs like benzocaine, nitrates, dapsone. The patient may look chocolate brown. Again, think of a co-oximetry to get an accurate reading. So, uh, mm, I just suggest you about the pulse co-oximetry. It is a device like a pulse oximetry which uses the Lambert's law. It identifies the arterial hemoglobin from the tissues and venous signals, but it adds more wavelength. It uses different light wavelength to determine the concentrations of other hemoglobin species, while the pulse oximetry only can get the informations on the oxygenated and deoxygenated species of hemoglobin. Pulse co-oximetries can give away more informations to determine the concentrations of other hemoglobin species. So typically it is able to report the concentrations of carboxyhemoglobin and methemoglobin. And while the co-oximetries are often more expensive also less available and still have the same limitations, especially at the very low saturations or in poor perfusions. They are not the replacement for the ABG, but they are powerful tool in a right context. So this is all about the pulse oximetry. Now let's summarize for practice. So SpO2 is a continuous trend. Do not treat a single number, treat the trend and treat the patient. Another, always check the plethysmograph waveform, and low perfusion, arrhythmia or venous pulsations can cause error. Keep that in mind. Cooxyhemoglobin and methemoglobin gives false reading. Keep that in mind. Dark skin can mask hypoxemia. When in doubt, always go for an ABG, and if available, go for the co-oximetry. Pulse oximetry is a miracle of biomedical engineering. However, it is not the replacement for clinical judgment. Now, think of the last time you saw a pulse oximetry reading that didn't match the patient. What was the cause? Motion, perfusions, or cardiac output? If you are in a training, I challenge you to go to your ICU today and find one patient whose waveform is poor. Figure out why, fix it if you can. So post your cases in the comment. Let's learn from each other. Thanks for the deep dive. If this video made you smarter than when you started, hit like, share it with someone who still trusts the number more than the patient, and subscribe because critical care doesn't wait and neither do we, right? See you in the next video. Signing off.